It's a great pleasure to introduce today our distinguished professor, Felipe Kitamura. Felipe is a real leading light in the world of AI in diagnostic radiology. He has been involved in leadership roles with RSNA and SIM. And one of the things too that currently he's the chief medical officer for Bunker Hill, which is an affiliated, federated model of diagnostic AI amongst academic medical centers. And it's a group that's been involved in we're partnerships there as well. But prior to this work with Bunker Hill, he had this great run of over 6 years working for this large hospital system in Brazil with 20,000 doctors and 2,000 radiologists running both imaging and hospitals across Brazil. And he ran the data analytics for this whole operation, for operational AI and scheduling and imaging, and really he has a unique perspective on how data science is going to impact us in radiology and beyond that as well. So, and I would try to, parenthetically, try to recruit him to Iowa, but was unsuccessful with that. But I think there's more and more pull to the States, with this Bunker Hill now, and we'll see. But at any rate, it's a real pleasure to have him here, and I think through this talk and tomorrow with the residents and people who learn a lot about where AI is today in our specialty and where it can be. Thank you.
Well, thank you for really excited to be here today with you all. Thank you so much for the invitation and for also you can give a discount, part of what Dr. Durden mentioned. So I wanted to share with you part of what I've seen the past years happening in the AI world in radiology. And one interesting thing about AI is that today you can just ask AI to create a picture or a lecture with this title and create this something that we would never imagine to happen until years ago. These are my disclosures. And I wanted to start by mentioning what happened back in 2015. Please raise your hands if you remember this, or if you knew about this. So I have a sense of it. Okay. So basically, Jeffrey Hinton is an AI researcher renowned. He invented many of the technical aspects of AI. People consider this is a very important person. And back then, in 2016, he said that we should stop training radiologists now, because it's clear that AI, in this case, deep learning technique, is going to do better than radiologists in 5 years, maybe 10 years. And it's been 8 years since then, and that has not happened. And actually, we're seeing the opposite happen. At that same time, another important AI researcher in Stanford, Andrew Ng, he has many, by the way, many good AI courses online. Should radiologists be worried about their jobs? Breaking news. This is a paper they published showing that AI was better than radiologists in diagnosing a woman. And Andrew Ng, I know he changed his mind because he started to work with the radiologists at Stanford, Kurt, Matthew Lundgren. But it seems Jeffrey Hinton is still thinking the same way today. So we'll see. And I'm telling you part of this story because it was around 2017 that I finished my fellowship and I started to work with AI in this private practice that Dr. Durden mentioned. And at that point, every radiologist I knew, all my colleagues were looking at me and saying, like, why are you helping develop this thing? This guy just said that this is going to replace us. And this is where I was in 2017. But after deep diving into it and starting to create my own AI models, it became clear to me that this thing is not going to replace us, right? There's a lot of hurdles that need to be solved for us to get the AI tools into practice in a way that really helps us. So I'm not saying that this is true forever, but at least as of now, it's. And since then, I've been working at this company trying to validate AI models, trying to deploy models in practice. And the reality is often less sexy than what we see in the news. And there, we validated more than 30 different models, mostly from startups, some of them developed in-house. And we were able to deploy a small number of those, between those 30 ones. And in these pilots, in specific scenarios, we tried to measure the benefit of AI. And it turned out that most of the models did not bring the benefit that we anticipated. So we just had two that we were able to measure the benefit, and then it made sense to deploy at scale across the institution. So I'll mention some of these. This one is not deployed at scale. This is one that the abdominal radiologists found useful, which is basically quantifying visceral fat, subcutaneous fat, and also bone mineral density from the lumbar spine. So AI segments those structures and measure things and give us more information. And we can use that as opportunistic screening, or we can use that to compose cardiovascular risk of patients. Now, this one here was a model that we were able to deploy at scale. And basically, this is an automated pipeline to read all the reports that were done in the previous day using AI to identify 50 different diseases, and diseases that we know there is a next step that is clinically pertinent. And then, so these models read those reports to identify those diseases so we can navigate those patients. So there are two main benefits here. One of them is guaranteeing that we communicate the findings and patients get the treatment they need. And the other one is, and this is especially important in São Paulo because we have many different health systems there. Sometimes patients don't come back to our health system. So if we communicate, there's a higher chance we can bring those patients in, and that also increases revenue for them. So this one worked pretty well. And one thing that we developed there is this pipeline that helped radiologists create more models in an easier way. So it would take 24 times less time to develop each of these single. Another model that was pretty useful in that institution is the MRI acceleration model. The idea behind this one is simple. We just reduce the number of averages during acquisition, which makes the acquisition faster. But then the image that comes out has more noise than usual. And what the deep learning model does is to reduce that back. There's a lot of validation here involved. It's a lot of work in terms of adjusting all the protocols, guaranteeing that we have everything for every machine, every outpatient clinic. It's a lot of work that is not related to AI to make this happen, but still, we had benefits for patients because patients got to stay less time inside the scanner, which is more comfortable. It's also easier to book because you have more time slots. And ironically, 6 years from Jeffrey Hinton and from my colleagues there pointing fingers to me, what happened was the opposite at the institution. We had more MRI scans to be read. And now we face the same issue here of shortage of radiologists there in Brazil too. And this is going in that direction of actually generating more. in deploying these models, this is a paper from Google that shows that the AI part, here's the black box there, the small black box. To make AI work in practice, you need all these things around, like machine resource management, IT infrastructure, analysis tools, monitoring, data collection. And that's also true for AI in healthcare and in radiology. But in healthcare, we also have all sorts of other things that we need to take care of. HIPAA, FDA, workflow, we need to make sure that AI can integrate. We were talking about this earlier today with Dr. Juliana. So it's a lot to do to have AI in practice. And I know that Dr. Gaskin is doing a good work in that sense of making it viable by having a platform so we can have most of these things sorted out without to sort out all those details. But what I've shown so far is related to some of the work that I've done at SASA, but now I wanted to share with you some of the recent advancements that we are seeing in the literature too, because people are trying all sorts of interesting things with AI, not only with the AI that we know from 2016, but also with large language models like ChatGPT-2. So this is a recent paper, came out in August, where they used this commercially available tool to identify normal chest X-rays. And the interesting thing is, in the hospitals where they tested it, almost 40% of the studies were unremarkable. And given this prevalence of disease, of normal studies actually, they could exclude pathology in 25%, given a sensitivity of 99.9%. But if you reduce the sensitivity, you could exclude pathology in even more studies. And that would correspond to a volume from 9 to 20%. So imagine, in a scenario where we have a lot of studies to read, what if AI could help us identify those that would not need our attention, at least not now, because they're probably normal studies, and this is what they show. But the other piece of information that is important here is if you pair the AI sensitivity to the radiologist sensitivity, which was 87%, AI missed more critical findings. So we might need a higher bar for AI because we don't want to miss more critical findings that we're missing today. The other interesting use case for AI, and here using ChatGPT, is to define the best study for a given clinical scenario. They used the ACR appropriateness criteria as a reference, and they created 50 different clinical cases across all body parts. One important thing to mention that this study was performed in Germany in a center where most radiologists were generalists. So you did not have a body imager evaluating the body cases. You had a generalist evaluating all cases. And in that context, they were able to, they've shown that if you just give GPT the way it is, it's not that good, but if you give GPT the ACR appropriateness criteria, it's able to identify the correct protocol with an accuracy that is higher than the radiologists there. And for AI to read an entire page, it's much faster. And the cost is also lower because it takes a lot less time to do that. So they're showing cost benefits, also time reduction. But still, there are cases that AI misses. And the thing is, are we ready to use a tool that is not perfect? Because if we're replacing the person for that specific task, what's going to happen when that tool gets it wrong? We still don't have a good answer for that. people have shown that GPT is also good in answering questions that are quite similar to the ones in the radiology board examination. It was able to get 69% of those right. That also happened to the USMLE questions. And this is actually a leaderboard that is live today. Every week, there's a new model that performs better than the other one. I think the top one right now is not this open evidence. I think the Google one surpassed it. We did a similar study with the Brazilian radiology board examination, and ChatGPT, GPT-4 was able to get 81% of the questions right too. So it knows a lot about technical information in medicine. But the question is, does it know enough to work on real world clinical data? And people are starting to pass that too. But most of the papers so far are focusing on questions and not real cases. In this study, they tested 30 different emergency cases. But still, it's far from reality, because when you are in the ER seeing a patient, the patient does not come with a page with all their information written there and all sorted out. You have to ask questions. You have to find out yourself what are the best questions to ask. So in this sense, this was not a real test. But in the other sense, they had clinical cases from the ER. And if you consider accurate, if the correct diagnosis was within the 5 top differential diagnoses, GPT was able to get 97% of those correct. And the physicians in this study, 87% of those correct. So, we can see that it knows something about medicine. The other interesting study that generated a lot of controversial thoughts was this one here. Has anyone seen this study? Please raise your hand. So just like, okay. So in this paper published in JAMA, they studied the answer that physicians were giving in a public social media forum to patients. So patients had their questions about their diseases, and physicians were answering those in social media. And it happens that the technical quality of the answers and the empathy of those answers were higher for the ones created by this chatbot when compared to the answers provided by the physicians. And, I started to see people saying that now AI will replace doctors because, they know more and they are also more empathetic. How come you will not, choose AI instead of a human physician? But the thing is, these people were doing this in their free time, like as a voluntary work. So, I want to help as many people as I can. I will not say things like, oh, I'm so sorry that you have that problem. I wish you weren't in that situation. I'm not writing that. I'm just like answering the question, And AI, as you may have tried already, you can see that ChatGPT does that. It has all this like way of writing. So what I think when I see something like this is, what if those physicians answering those questions had the chatbot answer as a template provided for them, and then they can choose to just sign off, or if they want to edit or reject it, they could do that. Maybe if we had that, we would have an outcome that would be better than physicians alone or the chatbot alone. This is what comes to my mind when I see things like this. People are using large language models like ChatGPT, like Claude and others to detect speech recognition errors. Radiology reports not only related to speech recognition, but also any kinds of errors, and it's quite effective. It's not perfect, but it's really good, and it's good. It's better than the tools that we used to have before. Now, I'm only mentioning here the good side of it, like showing what is possible and what people are testing, but the reality is that validating these large language models, it's like hitting a moving target. And we know how hard it is to do that. So always bear in mind when you see these studies that there are caveats, there are limitations, and most of these limitations are related to the fact that these models were trained with public information on the internet. So you don't know if the information you're testing your model was not used to train it. That's one of the main issues in validating those models today. Now I'm going to switch gears here and talk about another topic in AI. And to start talking about that, I'll give you a brief context, which is, remember when I mentioned when we as physicians see a patient, I mean, as radiologists, we'll almost never do that, but you got the idea. Would you imagine a scenario where the patient comes in, brings an X-ray, you look at the X-ray, you just say, you have a fracture and goodbye, right? This is not what happens, and I'm creating this scenario because we as physicians do more than look at X-rays or MRI or anything else. There's a lot of tasks that we need to do to actually help patients. And going back to the basics in medicine, there's a lot of information in patient history and physical examination, vital signs, formulating differentials. And then we start to ask for diagnostic tests. We assess all the entire case, we plan. We need to educate the patient to see if the patient understood what we said, if they're following what we're saying. And I'm mentioning all of this because we are seeing this direction in AI where what if we could show AI all the information that we have for that patient, not only the imaging studies, but lab tests, information in the EHR, prior history, information about microbiome, all the omics, proteomics, transcriptomics, and some of these things are far from our reality, but other ones are quite close. Wearable information from biosensors and wearables. What if we could do that? So until recently, we focused on having AI look at medical images, and that's it. But there's this recent 2017, when this came out, this deep learning architecture called transformers that was developed by Google that is capable of reading images, reading text, reading audio, reading everything, every different type, every different mode of information. And this is why this architecture transformers, they are good for multimodal AI. So this is not entirely a new concept in our field, but it's quite difficult to implement this, mainly because there are many technical hurdles around this. Like, for example, getting information across all the different silos that we have in healthcare. So imaging information is in the text, other information is in the list, other EHR, so that's the difficult part of it. Now, multimodal is also related to another concept that I wanted to share with you today. And this other concept is called foundation model. Has anyone heard about this term here? Please raise your hand just so I. Okay, so this is a definition of foundation model that was actually created by a foundation model, which is GPT-4o. So basically, imagine if you had an AI model that by itself, it doesn't do anything. But it's quite easy to create specific AI models for specific tasks. You would need much less data. You would need less annotations. And even though you would be able to create a model to identify intracranial hemorrhage, pneumonia, pneumothorax, or any other disease that you want, or even segment those diseases. So that's the idea of a foundation model. And to create one, you need a huge model, a lot of compute resources, and a huge data set. So it can train itself. And the interesting thing is, this is mostly related to the quantity of data and compute. You don't need labels here. You don't need us radiologists telling what there is and what there is not in each imaging study. You just need the images and the reports. And it can learn by itself, just like they did with GPT. So this is the pre-training part of it. And hopefully, if it works, it's gonna become a lot easier to develop new models now on. Meta AI, former Facebook, they developed this Dino P2. This is a kind of foundation model for natural images. It was trained without labels, just the images themselves. And as you can see here, it's able to segment a dog in the video, in every frame of the video, and it works pretty well. It can do that with all sorts of natural images, for example, in this case. And we can wonder, what if I put a chest x-ray or a brain MRI or something like that? And I did this test with a lot of different imaging studies, and this was the result for most of them. As you can see, it doesn't work at all. It's like the total mass. It doesn't identify any differences within the brain. But my point here is, if we fine-tune those things on medical images, they might get good at doing that in medical images too. And some papers are trying to do that already. We have some evidence that this will probably work. These are smaller scale studies. They are not in the scale of hundreds of millions of studies yet, but they're showing interesting results. For example, in this case, they created this radiology version of Dino called Red Dino, and this is a paper by Microsoft, where they show here in the red line that Red Dino was way better than the other counterparts, the other parts that do not need labels. But if you compare with the ones that use labels here in this dotted line, then it's not better than that one yet. But we're getting there. Now, in this other work, also from Meta AI, they also fine-tuned Dino for radiology, and they call this Ray Dino. And they tested for classification tasks and for segmentation tasks. As you can see, segmentations look pretty good. But if you look at the metrics, they were able to get state-of-the-art results for some classification tasks using this self-supervised approach, which means you did not provide labels to the model. It learned by itself just by seeing the data. So that's where we are. But it was not the best model in all scenarios, but it was state-of-the-art in some of them. Now, the most interesting thing about Ray Dino is that it was able to generalize to rare diseases. So if we remember how AI works, we need a lot of data, a lot of labels so it can learn. But in this case, it was able to do pretty well in diseases that are rare, which is interesting because AI didn't used to work that way before. And the other thing is the data sets they used were before the pandemic. So there was no COVID. But even then, these models were able to spot that some of the chest radiographs had a different kind of pneumonia. And when they looked at those cases, those were COVID cases. So again, this is an evidence that it's able also to identify diseases that it has never seen before. So a lot of promises in that sense, but nothing coming down to reality yet. But as we're thinking and talking about the future here, I think this is one of the areas that we should follow closely. And OpenAI, before they were closed AI, they published this paper that, in a nutshell, what they've shown here in this paper is that there is no diminishing returns yet for foundation model. That means the more compute, the more data you put in, the less, the more you reduce the error of these models. So we are still in that phase where we just need larger data sets. We have not reached diminishing returns. There are some papers testing AI models, foundation models to generate radiology reports. And this was an interesting one from Google where they show that reports generated by Matt Palm, they were preferred over those produced by radiologists in 40% of the cases, which is a piece of evidence that these models are getting better. So imagine if you had an assistant on your side that will generate template for reporting for you, and you would feel that's a good enough report in 40% of the cases. That could help us be more productive or reduce our burden in reporting. And the technical aspect of creating such a model, and here I'm showing side work that I'm doing with some colleagues. It's not that difficult to put together such a model that you give the image and it generates the report. The difficulty here is to validate those reports because there is no automated metric to tell you that the report is good or not, or how good or how bad it is. We need a radiologist to read every report and say if it's good or if it's not. So today, the main hurdle in developing these models is identifying an objective way to assess the reports. And people are trying to solve that problem, but it's still unsolved. So Google has this Gemini family of models that they trained on genomic data, skin pictures of skin lesions, pictures of skin lesions, mammograms, brain CTs, pathology slides, you name it. They've trained these foundation models on everything, and they are validating those in public benchmarks. As you can see here, some of these benchmarks are related to question answering, which is, it tests some of the medical knowledge, but it's not clinical oriented. But other ones are more clinically oriented, like report generation, for example. And these models are performing pretty well for these tasks. But still, what my point here is, even though most of the things here are blue, that doesn't mean this is clinically translatable. Now, has anyone seen this before? This popped up Twitter a while ago. Have you seen that? Raise your hands. Oh yeah. Yeah, that's just the reality, right? In 2016, we thought we would lose our jobs to replace them. And the fact is, we're still using regular cars to try to work right now. So this is what happened so far. And my question is, what's going to come from now on, especially with foundation models? That's still the quality thing for me. Because there's a lot of potential, but are we going to be able to actually do that research and get the results that we want? And final thing I wanted to mention too, and we were also talking about this earlier today, is that in this imaging cycle where the physician has a question and wants to solve a clinical problem, then the physician needs to decide which study is a good study to request, or if you need any. Then you need to schedule to acquire the images, process the images. Then there's this part of perception and reasoning that's mostly what we do as radiologists, and also community reporting and communicating. But when we think of AI, we usually think of AI doing these tasks. But the reality is there's a lot of value for AI in these other tasks in the imaging cycle, in helping the decision-making as a clinical decision support, scheduling the studies, even predicting which patients will not show up the next day. There are models doing that quite well too, acquiring images in a faster way, processing those images, and also helping out in the reporting part and in the communication part. So as take-home messages, I wanted to mention that AI continues to evolve. AI is getting closer to meeting clinical standards for some tasks. And we were also talking about mammograms here. There's a lot of interesting evidence coming out about using AI for breast cancer. Multimodal enables AI to see more, and the transformer architecture enables multimodal AI. And transformers have not reached diminishing returns with increasing data yet. And foundation models need much less data to train downstream models, which will hopefully facilitate the creation of more AI models for radiology. And we see that machines are getting more intelligent, but are they smart enough right now? I'll leave you with that question. And before I finish this talk, I wanted to share with you what I've been hearing from my colleagues in the past 7 years about AI and radiology. And after that, I'll share with you so basically what I'm hearing from my colleagues is that radiology has always been a great profession, but the truth is times have changed and professions changed. We have to acknowledge the pride of being a radiologist is over. No one will believe that radiology will change for the better. Everybody needs to know radiologists will have no value. You shouldn't believe when somebody says radiology is being reinvented. But now I think we need to see things in a different way. And my opinion is that radiology is being reinvented. And you shouldn't believe when somebody says radiologists will have no value. Everybody needs to know radiology will change for the better. No one will believe that the pride of being a radiologist is over. We have to acknowledge times have changed and professions change, but the truth is radiology has always been a great profession.
Now we have time for questions. Yeah.
So I think a place where I struggle is, especially with these transformer models, is even at the level of like academic institutions, let alone me sitting in my home trying to figure out how to train these models, is, I don't have 20,000 H100 GPUs. So like, how can, individual research labs, or what are your thoughts on how individual research labs or places that are not Meta or Google or OpenAI actually contribute to this research in a meaningful way? Because I mean, even trying to fine tune some of the llama models, like I don't have the GPU capacity to do it. So I don't know if UVA does. So where do we start?
That's a really good question. And I'll start, and my short answer is join Bunker Hill. No, I'm just kidding. This is my disclosure here. I'm working for Bunker Hill, and we're developing a foundation model. But to your point, you're right. You're right if you want to work with foundation models. Then you need that scale of compute, but not only that, you need that scale of data as well, which is also not that easy to find and get access to. But there's a lot of AI that is not related to foundation models. You can still train your segmentation models, your NLP models. You can fine-tune GPT, for example. They have APIs to fine-tune GPT if you want. I mean, there's all sorts of data privacy issues that we need to take care of, but that's also accessible. And if you really want to work with foundation models, the interesting part is that those scaling laws that I mentioned, that is the way to work with foundation models. And that is accessible to everyone because that means you can do experiments in a smaller scale and increasing scale and show where you're going. And then you can predict, what if I create a model that is 1,000 times bigger? I know where I'm going to get. So that can also reduce the risk of this kind of research because you don't get that many tries to use 10,000 A100s for 3 months just to find out that you were wrong, right? So that's how people are using these scaling laws to identify the trend before you go to the bigger experiment.
How do we gain control over the quality of that data that is being used to build those foundation models? Because it seems to me that it's so large and so open to the public that we really have no idea what quality of data we have, that it's drawing the conclusions that we're going to work with.
That's also a great question. And this is something that will need to be, this is a research question, actually. I don't have the answer for that. But we know what people have done for GPT, for example. There is a huge part of the work that is done in curating the data sets. So they scrapped the entire internet to get everything, but there are a lot of duplicated things. There are a lot of noisy things, wrong things. A lot of the work goes to curating that. And curating medical images and curating medical imaging reports it's quite different from curating like general content in the web. So we still need to sort that out, but you are totally right. This is something that needs to be done so we get most out of it. I know that just from the scale, the big scale that we have, we're able to get good enough models. But if we curate those data sets, they become even better. The models become even better.
Speaking to timelines, I was thinking of the slide where you had like 30 validated scales and then it said like two large upscaling. What's the timeline of getting a process validated? And then what's the timeline of once you decide to go large scale with one of the models to get it integrated into a hospital system?
That's also a very good question. And it's highly dependent on the process that each institution has to do that. And maybe Dr. Gaskin would have a better answer to that one than Dr. Durin because they know about the UVA things. But I can tell you about how it worked at DASA. It started with no governance, no process at all in the beginning. And it was really difficult to navigate. And it took us a lot more time than we would need if we had some rules in place on how to do that. But yeah, you want to make sure that all the important stakeholders know about it, that they have a say in what you're doing. Not only the clinical side, but legal, IT, everything else. And making sure you have buy-in from everyone is a difficult task. So it usually takes a lot. I mean, the idea is simple. You validate the model, you see if it works. You get a data set from your institution, you identify, send to this company, they process it with their AI, they give you the results back, and you measure how well it does. That's one part of it, validating if the model works. But then there's all sorts of things like if you're going to deploy it, where is this data going to go to get the inference from AI? Is it the cloud? Is it on-premise? There are privacy issues that you need to sort out within the institution. Can I do that? Can IT prioritize this project? Or is IT worried with tax migration or other things that are more important because they're clinical things? So it really depends. But at DASA, there was a model that took us 2 years to deploy. And during the pandemic, we were able to do that in 3 months for the COVID lung segmentation model, CT, to quantify ground glass capacity. So that's the time range that we have had there.
It's a good question, Connor. I mean, and it's playing out across the nation in terms of, and different institutions are further down the path, but it's governance. Like how does an institution make decisions about what to invest in and how to allocate its resources? What's the priority? How do you set the prioritization? And then that really nice slide that you had, Felipe, about where the machine learning sits in that whole world of everything else related to it. And it's really having that data governance is just a piece, not just data governance, the governance of the system. It's all of it comes to play. Yeah.
There's another.
Yeah, I have kind of maybe a little bit of an abstract question. Yeah, I guess I'll sort of preface it with, a lot of radiology since the inception of radiology is really focused a lot on things that can be seen macroscopically. So, discrete foci, things that can be sort of, visualized at a workstation and a qualitative report can be generated around. And so, there's been a lot of effort related to the use of AI towards segmentation and the definition of specific features that are descriptive in some way of those specific lesions or other things that can be seen on diagnostic imaging. In parallel, over in the research realm, there are all these different approaches that are being used that don't generate information related to discrete foci. It's far more abstract. It's far more numerical in nature. So things like functional connectivity, diffusion tensor imaging, and other things that functional MRI and other things that are really, really useful on the research side, but you can't really talk about them in the context of the individual. You have to talk about them in the context of populations and looking for statistically meaningful associations between things that differentiate the populations. And, so when you think about foundation models, are foundation models going to bridge the gap between the ability to be able to bring some of these advanced imaging methods that have been really useful in research over into the clinical setting when you can actually start talking about them in the context of the individual?
Wow, that's a very good question, and by itself, I don't have the answer. My short answer is I don't know the answer to that, and I think that's also another research question. Since these are all new things, I think we don't have the answers for most of those. But I see your point that we might be able to leverage a foundation model, for example, to make those assumptions not only the populational level, but also to predict for every single patient. I wish that's the case, but I'm not sure that will help me out. I don't have the answer for that.
Right. Let me close here. We have a small gift. So I took Dr. Kitamura on a walking tour around the lawn. Got him a heavy dose of Thomas Jefferson. And also, what the uniqueness of this institution and how, forward thinking he was in terms of what an academic village looks like and how knowledge is at the center of it, not a church. And really this birth of humanism and what a wonderful architect he was. We have Jefferson Cup, which is another one of his designs. And thank you for your contribution to this community of learners and to the knowledge as well. Thank you.
No, thank you so much. I mean, I really appreciate it. You couldn't have.
Thank you all. And so we'll have Felipe really for the rest of the afternoon, residents tomorrow morning, and
Thank you.
yeah, so thank you all for questions.